uh, our YouTube channel later on. You guys can see the slides. Okay. All right. So thought we'd talk a little bit about traumatic cerebrovascular injury. This is a little bit of a subject that's kind of near and dear to my heart, because I think when I first got to Elmhurst, we didn't really have any protocols in place for kind of routine screening of cerebrovascular injury. And over my short career, I've come to realize that, just how common this really is, and how life-threatening, obviously, these injuries can be, and how there really is an opportunity if you have, if you're thinking about these injuries and you're thinking about this in patients with traumatic head injuries and traumatic spine injuries, that you can really catch a lot of things early on that can be then treated and avoid complications down the road. So I thought we'd just go over a little bit of kind of the pathophysiology of this. And we're going to talk about not just blunt cerebrovascular injury, but we're going to talk about also traumatic venous injuries, which are also usually blunt, but also penetrating cerebrovascular injuries, and then a little bit about post-traumatic vasospasm. And if we have some time at the end, I have some cases throughout, but I also have some additional cases at the end that are more recent. So in terms of blunt cerebrovascular injury, we'll start off with a case that Dr. Margettis may remember. But this was a patient that had a right vertebral artery occlusion after a C3 fracture dislocation. He was a middle-aged taxi driver and got into a motor vehicle accident. He was GCS 15 when he arrived, but he did have bilateral upper extremity weakness. Lower extremities were intact. He then decompensated in the trauma bay and needed to be intubated. And he was found to have kind of this dish-like spine with some bridging osteophytes in the ventral vertebral bodies, and this fracture dislocation at C3. And on CTA, he had an occluded right vertebral artery, which you can kind of appreciate in this upper right. You can see his left vertebral artery, you can't see his right vertebral artery. And then on the coronal recons, you can see that the right vertebral artery is missing over here. So this fracture was unstable. He had an Asia D spinal cord injury. And we'll kind of get into what happened with him a little bit later. But blunt carotid and vertebral artery injuries are historically were thought to only represent really 1.1% of blunt trauma admissions. But this was really before there were routine screening of these patients. And so this really just related to those patients that had symptomatic injuries during their admission. So what's known now is that if you are actually screening these patients, that it's about 1% of all blunt trauma patients will have some form of blunt carotid or vertebral artery injury. And if you look at those patients that have an ISS greater than 16, so those patients that are more severely injured, it's actually almost triple that. It's about 2.7% of patients. So it's rare, but the complications that can come from this are potentially devastating if left untreated. So in series where they, for whatever reason, didn't treat these patients or didn't pick up the injury, and then until it became symptomatic, the mortality rate is actually can be quite high, upwards of 23 to 28%. And even in those patients that survive, there's a severe neurological morbidity related to strokes. So really the screening and treatment of blunt cerebrovascular injury is aimed at reducing the stroke incidence and thereby reducing the mortality and morbidity for these patients. It's also important to realize that bilateral injuries are common. Almost up to 0.25% of injuries can be bilateral. The carotid, the anterior circulation is more frequently injured than the vertebral artery or the posterior circulation. However, obviously, this depends upon really the area of the injury and the mechanism. So usually when we're talking about carotid injuries, it's often skull-based injuries, whereas vertebral artery injuries are typically more cervical injuries, although you can obviously have carotid injuries with spine trauma as well. Motor vehicle crashes, at least in the United States, are typically, at least at the time that I put these slides together, which was initially a couple of years ago, with motor vehicle crashes were the most common form of blunt cerebrovascular injury. But in patients that are more elderly, which is our growing patient population nowadays, ground level falls are actually the most common cause of blunt cerebrovascular injury, accounting for about 2/3. So this is expected to grow, and probably as time goes on, we will see that more of our blunt cerebrovascular injury is coming from falls and other mechanisms other than motor vehicles. Um, so there are different ways of classifying blunt cerebrovascular injury. One way is by the mechanism of injury. And in this classification system, type 1 injuries are really those that are caused by direct cervical trauma. So a seatbelt injury or strangulation or a near hanging type of injury. And this counts for about 10% of blunt carotid injuries. Type 2 injuries are those that we are often thinking about when we have patients that have cervical trauma. So cervical hyperextension or flexion with rotation. This is the most common mechanism. And in terms of carotid artery injuries or ICA injuries coming from this, it's really caused by, or it's thought to be caused by stretching of the ICA across the lateral articular processes of the cervical, of the high cervical vertebrae of C1 to 3. So you can kind of see this in the schematic up at the top here. So A would be this twisting mechanism whereby the ICA is injured by stretching it across these articular processes. Type 3 is represented here by C in this diagram, but this is intraoral trauma, which is an injury to the ICA at the angle of the jaw. And kind of horrifically, the description that they often give for this is if you're walking around with like a toothbrush while you're brushing your teeth and you fall and you happen to fall, that's one not uncommon mechanism for type 3 injuries, apparently, is that so probably nobody listening to this will ever walk around with their toothbrush in their mouth again. Type 4 injuries are lacerations from basilar skull fractures at the carotid canal. And so these are, it doesn't say this here, but these are really the second most common after these type 2 injuries. Another way you can grade blunt cerebrovascular injuries is on the pathophysiology of the injury itself. And this is really grading the type of injury in terms of its severity. So a grade 1 injury, which is the least severe, is an intimal tear. So you get exposed subendothelial collagen, which causes platelet aggregation and thrombus formation. This can cause vessel occlusion in a delayed fashion, or it can cause embolism. So these are grade 1 injuries are still ones you would want to treat, as they can either cause embolic strokes or they can progress to a higher grade injury. Subintimal dissections can cause luminal narrowing, so flow limiting injury that would be classified as a grade 2 injury, or if it causes enough of a thrombus formation, it can result in vessel occlusion in the acute setting, which would be a grade 4 injury. Then you have partial or complete transections. So a partial transection where part of the vessel wall is injured, but the entire vessel wall may not be completely injured. So there's not like a frank hole necessarily in the artery, but multiple layers of the artery are injured. Or you have some initial bleeding that a clot forms. You can form a pseudoaneurysm, which is a grade 3 injury. And these are at high risk of rupture, even more so than a regular cerebral aneurysm, because these really have a false wall. It can sometimes just be the clot around, or just a very small amount of tissue left of the vessel wall. These aneurysms are also nidus for thrombus formation and embolism, and you can also develop arteriovenous fistulas as well. And then also, if you have just vessel rupture or transection of a vessel and hemorrhage, that's a grade 5 injury. So putting these together, this injury grading scale is the Biffle classification, and Biffle has a lot of obviously published works in terms of traumatic cerebrovascular injury, and a lot of the grading scales and a lot of the initial studies on this he was involved with. So again, here, injury grade on the left and the description. So you have grade 1, which is luminal irregularity or dissection with less than 25% luminal narrowing. Grade 2 is more than 25% luminal narrowing from a dissection or an intramural hematoma or an intramural thrombus, intimal flap. Grade 3 is a pseudoaneurysm. Grade 4 is an occlusion, and grade 5 is transection with free extravasation. And so these are just some pictures representing that. So at the top here, you have carotid artery injuries, and on the bottom, you have vertebral artery injuries. And so you can see on the left of grade 1, you just see a little bit of narrowing, or maybe no narrowing, but just on the CTA or an angiogram, you might see a little bit of an intimal injury. Grade 2, you start to have more than 25% narrowing, so it's now flow limiting. Grade 3, you can see here, it's a little bit easier on the vertebral artery one. You can see this little bleb, which is where the vessel's been injured and you now have a pseudoaneurysm. And then grade 4 is where you have complete occlusion. This may have started out as either a grade 1 or 2 and then progressed very acutely, and then become a grade 4 injury where you have complete occlusion. And then grade 5 is where you have the entire vessel is ruptured and you just have free extravasation of contrast here. So the clinical presentation of a patient with a blunt cerebrovascular injury really varies. It depends upon the vessel that's affected, the site of the injury, whether it's extracranial, intracranial, the particular distribution of the vessel, the injury grade, and also it can also depend upon whether or not they have pre-existing cerebrovascular disease, such as atherosclerosis, and how their collateral circulation is in the brain. So the majority of patients actually that have blunt cerebrovascular injury are asymptomatic of presentation. And so this is an important concept because this really is the reason why screening is important, because there is a latent period in patients that have injuries that are asymptomatic before they can start to develop symptoms. So 25 to 50% of patients develop their first sign or symptoms greater than 12 hours after the injury. And most strokes occur between around 12 hours to 75 hours after the injury. And the median is—
Sorry, could you say that again?
Sorry. Siri.
I'm having trouble hearing you.
Siri on my watch just decided to chime in. And it's about a median of 48 hours after admission. There have been some reported 14 years after injury, whether that's really real or not, but the point is that the majority of patients are asymptomatic when they present with a blunt cerebrovascular injury, and it takes a certain amount of time, anywhere from half a day to a few days for them to start to develop symptoms. And obviously, once they start developing symptoms, those are usually symptoms of ischemia or stroke. So what this means is there's really a window of opportunity to diagnose these injuries before they start to cause significant problems and treat them before they start causing cerebral ischemia or stroke. And if you look at older series where some of these injuries were left untreated for one reason or another, the stroke incidence can be quite high. So in patients with intimal grade 1 injury, in the carotid circulation, the stroke incidence is about 8%, and then in the vertebral artery about 6%. And then you can see as the higher the grade, that basically the higher the stroke incidence. So a flow limiting injury, almost doubles that for the carotid, and for the vertebral circulation, it's even higher, about over a third of patients. Pseudoaneurysms, you may not think, okay, well, obviously there's a risk of rupture and a risk of catastrophic hemorrhage from that, but there's also a risk of stroke because they are an area where there's kind of turbulent flow, and it can form clots in the pseudoaneurysm and lead to embolization. So it's about a 25% stroke risk for both carotid and vertebral artery. And then for an occlusion, it's higher. It's not 100% for occlusion because of collateral circulation that patients may have. And then for transection, at least in older series, it was 100% because there was in a lot of patients. So associated injuries. So there are often patients with blunt cerebrovascular injuries have a lot of other injuries going on due to the mechanism and the amount of force that's required to cause a blunt cerebrovascular injury. So patients with blunt cerebrovascular injuries frequently have head and brain injuries, often have maxillofacial injuries, and spine trauma. So particularly high cervical, C1, C3, as we mentioned, patients that have cervical subluxation, displaced transverse foramen fractures, and then chest and abdominal injuries as well. And in terms of the spine, it's not just cervical spine, but also thoracic spine trauma is associated with blunt cerebrovascular injury, both in the neck and cranially, but then also there needs to be a concern for aortic injuries, obviously, with thoracic trauma as well. The average ISS score for patients with blunt cerebrovascular injury is usually quite high, so because it's more common in those patients with higher ISS scores, so it's around 28. In terms of craniomaxillofacial injuries, those that have mandibular or Lefort fractures are common associated injuries. And then in terms of spine fractures, the patients that have patients with cervical spine fractures are more strongly correlated with vertebral blunt cerebrovascular injury than thoracic, which makes just intuitive sense. So in terms of signs or symptoms that patients may have after blunt cerebrovascular injury. So if you have signs and symptoms from a blunt cerebrovascular injury, these are emergent cases essentially, because this indicates that they are either having ongoing ischemia resulting in symptoms, or they're having hemorrhage resulting in symptoms. So, arterial hemorrhage from the neck, nose, or mouth, an expanding cervical hematoma, a carotid bruit in somebody that's young. Those are obviously things that would be concerning. What we typically find are kind of more of these latter, or the patient that has a focal deficit or a TIA-like syndrome that that's not explained by their imaging, or potentially, so we're talking about maybe they have a hemiparesis or vertebrovascular symptoms, or they have a Horner syndrome that we can't explain based upon their CT or spine imaging, or they have a stroke that you can see on the CT or MRI initially. In terms of risk factors are these are basically urgent cases. These are patients that may not have actual signs or symptoms of a blunt cerebrovascular injury, but they have other risk factors that put them at a higher, make them more likely to have a blunt cerebrovascular injuries. And these are patients where we would want to screen these patients to see if they have an asymptomatic injury that we can then treat. So these risk factors are down here at the bottom of this table. So patients that have Lefort 2 or 3 fractures, so as we mentioned, craniofacial injuries. So if you have a mandibular fracture, you would fall into that category as well. If you have a cervical spine fracture, subluxation, transverse process fracture, or a fracture of the transverse foramen, really. High cervical C1 through 3 fractures, any sort of basal or skull fracture, particularly those that involve the carotid canal or the peaches bone, a hanging type injury with a anoxic brain injury, or a clothesline or a seatbelt type injury with an abrasion. And then another one, more importantly, patients that have diffuse axonal injury, or even patients with a low GCS of less than 6 are at higher risk of a blunt cerebrovascular injury. And so those patients should be screened as well. And so typically what we do actually now at Elmhurst is we've expanded this criteria a little bit to capture additionally patients with vasospasm, but we typically will screen any patient that comes in with a GCS of 8 or less for blunt cerebrovascular injury. And then obviously anybody that has any cervical spine fracture, really anybody with a significant thoracic spine fracture, so like a subluxation or a fracture dislocation, anybody with craniofacial injuries like a Lefort 2 or 3 or mandibular fracture are all being screened. And then looks a little bit busy, but it's actually quite easy to follow algorithm that our protocols basically based upon, except for the fact that we kind of expanded our criteria a little bit, is from the Journal of Trauma. It's the Western Trauma Association blunt cerebrovascular injury algorithm. And basically, if you have signs or symptoms of blunt cerebrovascular injury, you should get an emergent vessel imaging, whether that's a CTA or an angiogram. A 16-slice CTA is usually sufficient, particularly in the acute setting, because these patients may be unstable. If you have risk factors for blunt cerebrovascular injury, then you should get an urgent CTA. And given the fact that, as I mentioned before, most patients have this window of 12 or more hours or so until they may become symptomatic, what we consider an urgent one is we would like to either get it on the initial CT. If we can't get on the initial CT, we usually want to get it on the second one. So we're really trying to get it within that 12-hour time frame. I think probably within 24 hours is doing a good enough job, but we typically would try and get it within those first 12 hours so that we can capture any asymptomatic patients as possible, and then triage them to see how we're going to treat them. So in terms of screening modalities, really a cerebral angiogram is the gold standard. However, it is invasive. And it carries a not insignificant risk, less than 1%, but not insignificant risk of stroke itself. as well as complications from catheter insertions such as retroperitoneal hematomas and contrast complications. It's also resource intensive and takes a longer time than CT angiography. So CT, high quality CT angiography is really now the preferred screening test for blunt cerebrovascular imaging. I will put the caveat that in a lot of meetings that I go to with other neurotrauma specialists, there are some neurotraumatologists that are also and happen to be endovascular neurosurgeons, and so they would argue that even though they may use CTA initially, they will almost always, any patient that they feel is at high risk of blunt cerebrovascular injury or has a blunt cerebrovascular injury will get an angiogram as soon as they possibly can as well. And they make the argument that even though the data would suggest that 16-site CTA has a very high sensitivity, that there are cases where they have noticed that they've either missed or under appreciated an injury on CTA compared to cerebral angiogram. So my bias is that I will usually get CTA first, and then if I think a patient is at very high risk or we know they have a blunt cerebrovascular injury, we talk to my cerebrovascular colleagues about potentially getting an angiogram while they're in the hospital. MR angiography has less bone artifact and it avoids contrast agents, allows earlier detections of infarctions, but it does have, compared to CTA and cerebral angiography, has poor sensitivity and specificity. It's also resource intensive, it's increased time. So it's not great for acute and unstable patients, particularly patients with head injuries where you don't want to lie them flat and put them in an MR scanner for 45 minutes or an hour. And there may be some implanted device incompatibilities. And then duplex ultrasonography really has such poor sensitivity for blunt cerebrovascular injuries. It's not really an appropriate screening modality. So in terms of treatment, it's important to realize that there's really no controlled trials, at least not that I'm aware of, unless something's come out very recently, but not that I'm aware of. There's really no controlled trials, no class 1 data, and no level 1 recommendations on how to treat patients that have blunt cerebrovascular injuries. So basically what we're limited to is case series, some lower class data and recommendations and consensus kind of opinion and expert opinion. So what most people agree is that antithrombotic therapy is really the first line treatment for most blunt cerebrovascular injuries. So grades 1 through 4 in particular. It does, in most studies, translate to reduced rates of neurologic morbidity and mortality. So in patients that are asymptomatic that are then treated with antithrombotic therapy, it's a pretty low rate of ischemic neurological event, about 0.5%, whereas in similar studies where they were untreated, as I mentioned before, the rates of morbidity and mortality can be upwards into the 20% range. So in terms of what to use for antithrombotic therapy, so unfractionated heparin, a heparin infusion is often used as the initial agent in patients that don't have a contraindication because it's reversible, and these would be in patients where they still might need procedures, still not certain whether they can be put on antiplatelet therapy or something that is longer acting or that's going to be maybe a little bit more difficult to reverse. And so unfractionated heparin is often the first one if in those patients where they still might need invasive procedures. And so we typically will do no bolus. We'll use a relatively conservative PTT time, so 40 to 50 or 40 to 60. There's no real clear time point of when this is safe in TBI. So maybe 48 to 72 hours post-injury. Now, this obviously presents an issue because 48 to 72 hours is when we said a lot of these patients are going to start to become symptomatic. So we will often push this earlier as long as they have a stable CT. So, if somebody's had a stable CT by 24 to 48 hours, we might push it into that range. Antiplatelet agents in terms of aspirin or Plavix are kind of traditionally considered a long-term agent, and there's really no evidence for the superiority of Plavix over aspirin. There's also no evidence that dual antiplatelet therapy is better than monotherapy and does have an increased bleeding risk. So actually what we do now typically is as soon as we can, we move to aspirin 325, typically because at least in my experience, aspirin doesn't cause bleeding. It just makes ongoing bleeding a little bit more exuberant and harder to stop, but it's not going to start bleeding where there wasn't bleeding already happening. So basically, once a head CT is stable, then I'm pretty comfortable putting somebody on aspirin. So I will actually tend to favor doing that rather than putting patients on unfractionated heparin first. And if we, the only caveat to that is if they're going to need surgery or they're going to need other invasive procedures, then it would have to be reversed. So we might need to wait from that standpoint, and then I would have to use unfractionated heparin. But as soon as, as long as we're either okay operating on the aspirin or they're had emergent procedures done that they were going to need done, I'm pretty comfortable putting on somebody aspirin around the 24-hour mark after a head injury. So surgical repair. Surgical repair of blunt cerebrovascular injuries is really limited to surgically accessible lesions, which is the vast minority of lesions. As you imagine, around the skull base and anything high cervical, C2 or even C3 or higher is going to be very, very hard to reach surgically. Patients without a profound deficit have improved outcomes with repair versus ligation. It's really not justified for lower grade injuries. So surgical repair, I mean, is pretty, it's extremely uncommon, and it's really for only for kind of case report like situations where a patient may have kind of maybe a dissection with a thrombus in a highly accessible region, and endovascular therapy is for whatever reason either unavailable or not able to treat it. But as endovascular therapy has become more commonplace and more advanced, it's really our treatment option for surgically inaccessible lesions and pretty much all lesions where medical therapy is not sufficient. So endovascular therapy still requires concomitant antithrombotic medications to be given to prevent reocclusion. So that's one of the issues. Because if you are going to do, say, a thrombectomy in a patient and remove a blood clot that is occluding a vessel, you may need to put, you're going to have to put them on antithrombotic therapy. After that, oftentimes you may need to use a stent or something like that to keep the vessel open, in which case they're going to have to be on dual antiplatelet therapy. So again, there's no controlled trials. There's clear indications are not yet developed. So a lot of this is still done on a case-by-case basis and based upon expert opinion and the clinical acumen of the treating physicians. It's really most useful in the following circumstances. So progressive flow limiting luminal narrowing, grade 2 injuries, complete large vessel occlusion without a completed stroke and with insufficient collateral circulation, pseudoaneurysm embolization. So again, not only do we want to mitigate the risk of embolization from these, but we want to mitigate the risk of rupture, as these are have a high risk of rupture, and the fatality rate from an intracranial, at least pseudoaneurysm rupturing, it approaches 100% if they're allowed to rupture, and they've given enough time, they will rupture basically almost always. So if you have a pseudoaneurysm, or at least like 50% of the time. So if you have a pseudoaneurysm, you're really kind of obligated to treat it as soon as you can. And then grade 5 injuries, transection. Oftentimes the treatment for that is going to be parent artery embolization to stop the bleeding and sacrifice the vessel. So going back to that patient that I presented at the beginning, this patient had the right vertebral artery occlusion after a C3 fracture dislocation. Dr. Margettis operated on this patient and did an amazing reduction. You can't even see where the fracture was basically on the post-op imaging, and stabilized the patient, instrumented him, and basically we got an immediate post-op angiogram. And this is back in the days actually when we had to send the patient to Sinai to get the angiogram. So this patient went to Sinai to get the angiogram, and then I think came back for the rest of the treatment. Now that we have a neuroendovascular program at Elmhurst, we can actually do these and keep these patients here in-house, which is great, which is really made our treatment of patients with blunt cerebrovascular injuries and traumatic cerebrovascular injuries much more robust. But you can see here that the vertebral artery is now patent on the, and so basically just reducing the fracture was enough to result in blood flow back through the vertebral artery. There was a small, very ditzel on the DWI, a stroke, a very tiny one related to this. And then because obviously this patient, had a traumatic injury, even though we couldn't see any necessarily intimal injury prevalent on the angiogram, we did place the patient on aspirin after that to make sure they didn't have, because they probably did have some sort of injury to the vessel wall that could properly promote a thrombus in the acute setting. So this patient did very well. So another concept in blunt cerebrovascular injury is that you should really repeat a CTA or a cerebroangiogram at 7 to 10 days post-injury if you found a blunt cerebrovascular injury initially, or if there's a neurological change. So essentially, if you find a blunt cerebrovascular imaging on your initial screening, then and you start treating it, you're not done at that point. You do need to follow these long term, and you should definitely get more vessel imaging around a week afterwards. And the reason why this is important is because follow-up studies change the management in more than half of blunt cerebrovascular injury cases. So grades 1 and 2, the lower grades, these frequently change. A little over half of grade 1 injuries actually heal in that time frame, whereas in grade 2 injuries, only about 8% heal. But if they heal, then you may be able to stop treating them sooner, and that may allow them to get off their antithrombotic therapy sooner and reduce the risk of bleeding and make further surgeries easier. Conversely, some of these progress to pseudoaneurysms because the vessel injury was a little bit more exuberant than initially thought, and it does take some time for pseudoaneurysms to develop, and so some of these will progress. So the minority of grade 1s progress to pseudoaneurysms, about 8%, but great for grade 2 injuries, because there's been a more significant injury to the vessel wall, about 43% of these will actually progress to pseudoaneurysms, and these are patients that are going to then need endovascular therapy to embolize the pseudoaneurysm. So you can see why it's important to do your follow-up, because if you were to miss this, then these patients would potentially be at high risk of rupture of that pseudoaneurysm and higher risk of stroke. Conversely, grades 3 and 4 injuries, so the higher grade injuries, rarely improve with time. So more than 50% of grade 3 lesions either remain stable or actually get worse. So these are pseudoaneurysms, right? So if you have a pseudoaneurysm and you leave it alone, it's not going to go away on its own very commonly. And so they'll often get larger, and as they get larger, be at higher risk of rupture. And so these really need to be treated endovascularly. Grade 4 injuries, so complete occlusions, are associated with high mortality. And the neurological outcome is proportional to the degree of impairment at presentation. Basically, what all this is saying is that if you come in and you have a neurological impairment related to an occlusion, that's because you have an ongoing stroke already. And basically, the worse your stroke is from the occlusion, the worse you're going to do, which kind of makes intuitive sense. This says repeat imaging may not be needed for grade 4 injuries, those with complete occlusion, and they will often recommend lifelong antiplatelet therapy. There's really no evidence for the benefit of delayed endovascular therapy. We will still often get delayed imaging because sometimes these do start to recanalize, and then they are at kind of higher risk of, if they had collateral circulation, they might be at risk of embolic strokes as well. So it's still probably a good idea to get repeat imaging on these anyway. So antithrombotic therapy should be continued until the lesion heals. As I mentioned, the optimal agent and duration is not well studied, but typically speaking, our go-to for long-term therapy, and we're trying to start the long-term therapy as soon as possible, as soon as we possibly can, is really aspirin. Aspirin 81 or 325. The data seems to indicate they're likely sufficient. We typically will use 325 just to be on the safe side to make sure we're treating it sufficiently. And again, delayed stroke has been reported out many years, although whether or not this 14-year-old was really real or not. But the point is that until the lesion heals, there is a risk of stroke until it completely heals. And there's the endothelial layer has been completely repaired. So in patients that have injury, you should also repeat imaging at about 3 months. And if the lesion is still there, then it should be on indefinite antithrombotic therapy. And usually these are going to be grade, 1 and 2 injuries and possibly 4 injuries, because grade 3 injuries, hopefully you will have treated and embolized them by 3 months already. So this is just a case of a 28-year-old man that was in a motorcycle accident that had diffuse severe TBI with a left temporal epidural hematoma initially. He actually had a CTA that didn't show any blunt cerebrovascular injury. And so, but then we actually got one on post-op day 7, partially to look for vasospasm, but he also had fractures that put him at higher risk. And so he developed a pseudoaneurysm. So I brought this up just because there's not really great guidelines on what to do if somebody is in the high risk category for blunt cerebrovascular injury and they initially have a negative blunt screening CTA. But typically what I'll do now, because of cases like this, is if they have a lot of skull base fractures and they're going to be in the hospital anyway for greater than a week, I'll often repeat a CTA 5 to 7 days out after the initial one, even if the initial one was negative, because occasionally, very rarely, but occasionally we will pick up a pseudoaneurysm that develops because there was probably some very, very, very subtle injury on the initial one that we couldn't see, and that developed into a pseudoaneurysm. So even if it's negative, if somebody is fitting into that really high risk category, I'll often tend to repeat it just to be sure. So key points for blunt cerebrovascular injury: it's not as rare as previously thought. 1% of all blunt trauma cases, and it's about upwards of 3% in patients that are more highly injured with an ISS greater than 16. About 1/3 of patients that meet the Denver screening criteria to screen for blunt cerebrovascular injury will actually have a blunt cerebrovascular injury. Most patients with blunt cerebrovascular injury are initially asymptomatic. There's a high stroke rate in those patients that are left untreated, and there's a high morbidity and mortality if left untreated. Having a protocolized screening is important, as this allows you to capture those patients that do have a blunt cerebrovascular injury and provides a window of opportunity for treatment of these patients. Symptomatic patients represent a neurological emergency. So patients that have signs and symptoms of BCVI should be assumed to have an injury until proven otherwise. And then the majority of those patients with blunt cerebrovascular injuries should be treated with antithrombotic therapy, possibly unfractionated heparin during the acute phase, but then transitioning to antiplatelet therapy, usually aspirin for long-term therapy. And then follow-up imaging is important to guide therapy, because almost 2/3 of patients will have a management change based upon the follow-up imaging results. This is another patient that had a left vertebral artery grade 1 injury after this patient had a left C3 facet fracture with some subluxation, and then had, you can see on the CTA on the upper left, it had a very small grade 1 injury in the left vertebral artery. They had a jump facet. They underwent, it was an unstable injury. They underwent surgery, and then after surgery, we started them on aspirin 325. This says a 3-month follow-up CTA was pending, but that was a while ago. So his 3-month follow-up CTA showed healing of this injury, and so we were able to transition him off of the aspirin. This is a patient that had a left cavernous ICA pseudoaneurysm, so a grade 3 injury. You can kind of see in the upper right image here, there's an arrow. If you can see that, there's a little pseudoaneurysm there. But basically, this was a 19-year-old that was in a motor vehicle accident. It's an unrestrained passenger at loss of consciousness. You can see in the upper left one, you can see all the pneumocephalus in the skull base. He came in GCS 17, but improved over time to GCS 15 within about the first day. He had multiple skull base fractures, including left carotid canal fracture, and then basal cistern traumatic subarachnoid and pneumocephalus. On his screening CTA, he had a left cavernous ICA pseudoaneurysm at grade 3. So he was started initially on aspirin 325 to prevent him from developing any clots in that could then embolize. And then he got INR follow-up in order to potentially to see whether this was resolving. So the reason we didn't get this embolized right away was because it was in the cavernous sinus. So if this did rupture, while it would be an issue, it wouldn't be necessarily fatal because it was not intradural. So had this been more distal in the intracranial circulation, we probably wouldn't have started him on 325 right away. We probably would have embolized that as soon as possible. And then potentially kept him on aspirin after it was embolized to prevent embolic strokes. But what this patient did develop in that first week was he developed a left cavernous carotid fistula on CTA that was then treated endovascularly as well. So traumatic venous injury. So we'll go over this. We'll go over some penetrating injury, and maybe I'll briefly touch on traumatic vasospasm. But you know, an underappreciated type of injury, I think overall, except to those of us that have to operate on these frequently, are sinus injuries. And so particularly venous sinus injuries, either the superior sagittal sinus or the transverse sinuses in particular, can be particularly harrowing in intraoperatively. But this is an example of a patient that had traumatic venous sinus injury leading to an epidural hematoma. So if we have epidural hematomas on the apex, they can obviously, those can be caused by a venous sinus injury. So this is a patient that you see a fracture. If we see a fracture in the midline, or we see a fracture going from side to side crossing the midline, or a fracture that crosses over the transverse sinus, we're always concerned about a venous sinus injury. So this is a patient that was hit by a car. It's GCS 15. Then he had a rapid decline in the CT, bradycardia, dilated left pupil, and then he had this sagittal fracture over the superior sagittal sinus. And then this is a good example why you always want to look at different sequences, and why it's important to get in addition to axials, to get coronal and sagittal sequences. So you can see that on the coronal and the sagittal cuts, and you can appreciate an epidural hematoma much better than before. So he went to the OR for a left decompressive craniectomy actually initially, and then what happened is once he was decompressed, the tamponade effect on the venous injury was removed, and basically this epidural hematoma, which was much smaller on the previous scan, it massively expanded, and this was kind of noticed intraoperatively because he was herniating his brain out of the craniectomy defect. And so the thought at the time is they weren't aware that that epidural was bigger, but they thought he might either have a contralateral hematoma or a deep hematoma or this epidural developing. So he went down to the CT scanner. They got the CT scanner showing this epidural hematoma and came back to the OR to have this evacuated. Post-operatively, he had significant edema. He went into ARDS, had refractory elevated ICP that required sedation, analgesia, hyperosmolar therapy, paralytics, and a brief period of actually pentabar coma. And then he actually did extremely well. He actually returned to a fully functional status. GCS 15, went back to work, and got his cranioplasty at 3 months, and then returned to full employment. So it was a great save by the team. That was Dr. Bayoun, operated on him a couple times. This is a posterior fossa epidural hematoma caused by an injury to the transverse sinus in the back. This was a 23-year-old who had fall, and then developed progressive headache and nausea, vomiting. He had this large left epidural hematoma from a transverse sinus and required a craniotomy for evacuation. I won't get into the specifics, but often they're very kind of interoperatively, there are specific things that we're often doing to ensure that we don't unroof the venous sinus when we are doing the craniotomy to evacuate the hematoma, because that can cause exuberant venous bleeding that is very difficult to treat. So we're often either leaving a piece of bone over the injury, or trying to leave a bit of the clot over where the hole in the vein is, and then tacking up the dura around it to either tamponade it, or being prepared to flat dura over the hole in the vein, and using adjuncts to prevent significant bleeding. Then the other things we're often worried about in the OR for these patients and concerned about is air embolism, because if we do have an injury in the vein and then it entrains air in the OR, you might get an air embolism as well. This is a patient that had a traumatic right transverse sigmoid occlusion. So this is a patient that had a large contusion and a skull fracture, but they also had a right transverse sigmoid occlusion. This patient needed a decompressive craniectomy and a partial evacuation of the contusion. And then later on postoperative, it was actually relatively delayed just because of the bleeding risk for this patient. We put this patient on a heparin drip and then transitioned them to aspirin, or transitioned them actually to anticoagulation long term. So key points, so fractures crossing the dural venous sinus, you should have a high suspicion for venous injury. Venous epidurals are less likely to expand. Small ones may be observed closely with serial imaging exams. Beware posterior fossa epidural hematomas, even if they're venous, because they can cause significant mass effect, and you have less room for compensation for that. Beware rapid expansion of a venous epidural hematoma following decompression for via hemicraniectomy, for instance. And then venous thrombosis, there's a risk for venous infarction and hemorrhage. This may result in hyperemia and elevated ICP. Venous thrombosis should be treated with early anticoagulation. So as opposed to antiplatelet therapy for arterial injuries, for venous injuries, we're using anticoagulation. You should consider endovascular thrombectomy for propagation on anticoagulation. Since it's already 8 o'clock, I'll just touch a little bit on penetrating cerebrovascular injury and then go to the cases. We'll skip some on the traumatic vasospasm unless people have questions. But this is just an example of a patient that had a midline gunshot wound to the head, and as you can see, it's crossing right through the ACA territory. So the main take-home point is that anybody that has any sort of penetrating injury, whether it is a missile injury or say a non-missile injury with a stab wound, you should always suspect that they have some form of cerebrovascular injury, particularly if it crosses a vascular territory, but I suspect it in anybody that has a penetrating injury. Those patients that have a missile injury are much more likely to have one just because of the cavitating effect of the missile and the fact that the injury can extend very far from the actual missile tract. So all these patients should get some sort of vascular imaging. Oftentimes, particularly if it's a missile injury, a CTA is going to be your initial go-to, just because these patients are going to have fulminant swelling, with cerebral edema, the elevated ICP, they're probably going to need to go to the OR pretty rapidly. So you're probably going to get a CTA first, but a CTA is really probably insufficient for them overall, just because missile injuries usually are gunshot wounds. So there's going to be a lot of bullet fragments, artifact on the CTA. So you're eventually going to want to get a CT angiogram kind of as soon as they are stabilized and are able to get a CT, able to get a cerebral angiogram, you're going to want to get a formal angiogram. In patients that have non-missile injuries, such as like a stab wound to the head or something like that, you're going to want to get a cerebral angiogram probably earlier, because the CTA, you're going to have more time. They don't have as fulminant swelling, so you're going to have the ability to get a cerebral angiogram rather than a CTA initially. This patient had multiple pseudoaneurysms. So you can see in this middle image, I'm not sure if you can see my arrow, but you can see these little blebs. These are multiple pseudoaneurysms in the ACAs. And so he got a cerebral angiogram after we had taken him he got a CTA initially, couldn't really see anything because of all the bullet fragments, but we assumed he had an injury. We took him and did a decompressive craniectomy, by frontal craniectomy, and then got him an angiogram afterwards that showed these pseudoaneurysms, which were then embolized. 2 years later, after multiple surgeries, cranioplasty, etc., he's actually doing quite well. He was able to return to a functional status at home. He comes to clinic by himself. He's got neurocognitive deficits, obviously, and behavioral issues related to the bifrontal injury. But so key points for penetrating cerebrovascular injury is that there's a high incidence of cerebrovascular injury, either direct from a penetrating object traversing a vascular territory or from remotely from the cavitation effect from a high velocity missile like a gunshot wound. vascular imaging recommended, I would say, essentially in all cases, unless it's, I don't, there's really not a case of a penetrating injury now where I won't get some sort of vascular imaging just to be on the safe side. CTA, if there's no retained metal fragments and initial screening, it should be the initial screening study in the hyperacute phase often, and then a cerebral angiogram, almost always, that's maybe your initial study if the patient had something like a knife blade or a nail or something like that, and you need it for your operative planning. You also have more time in those cases. And if it's something like a missile injury where you initially got a CTA because of the time constraints, and then getting a follow-up cerebral angiogram later once they're more stabilized. Endovascular treatment for pseudoaneurysms and vessel rupture, and then also follow-up studies if the CTA is negative or inconclusive. So again, this is all penetrating injury, they have such a high rate again that they should, even if the initial study is negative, I usually get a follow-up one just to be sure later. And then repeat the imaging 1 week, as I mentioned, post-PVI. Particularly with missile injuries, there's a higher rate of delayed cerebrovascular injury and penetrating injuries. So I'll skip over this, but unless people have specific questions about it, but I just wanted to kind of relate a couple quick ones. So this is a patient that we've been treating right now, actually, a 67-year-old where this car slid under the back end of a truck. He had a prolonged extrication time, GCS 6 in the field. He had a traumatic right globe rupture, left pupil was reactive, got a stat CT head and CTA. It's a little hard to appreciate here, but he had a depressed skull fracture on the right side that involved the frontal sinus and his cribriform plate, bilateral orbital skull fractures. He had a CTA, which it's very hard to see here, but the CTA on this left carotid, he's got a little kind of area where there's no contrast enhancement right in the center. So there was a thought that he may have a dissection of his left ICA. He got a right frontal ICP monitor placed. He had bifrontal contusions. It was actually, his ICP was controlled with medical therapy. He got a repeat CTA a few days later, which still showed the dissection. And we basically let him cool off for as long as we could, and then took him to the OR to repair his complex skull fractures. And then post-operatively got him a cerebral angiogram. We didn't aggressively treat him just because we weren't sure if it really was a dissection or not, and he needed so many procedures in the first few days that ICP monitor and lines and everything, that we didn't start him on aspirin right away. But he did get this is just some pictures of the OR. It's actually had the most comminuted skull-based fractures I've seen. So we did a complex cranial repair and attempt to repair his CSF leak. But this is his post-op angiogram that we got, and he's got an aneurysm just near the kind of proximal to the anterior clinoid. This would actually be a superior hypophyseal, probably actually aneurysm. If it was a spontaneous aneurysm. However, it's right in the right area, and it has some characteristics that we're highly concerned this actually might be from his trauma. And so they're actually discussing it this morning, and I think they're planning to probably embolize it in the next couple of days.
Sorry, I couldn't hear what you said.
And assume it's a trauma. So that's just it highlighted there in red. So with him, they're probably going to need, because of this location, they're probably going to need to do a flow diverting stent and then have him on dual antiplatelet therapy. So that's why it's a little bit tricky in his case, because he's probably going to need additional craniofacial surgeries from the facial trauma team as well. And then this is another patient that had a gunshot wound to the back of the neck while leaving a bar. So he was just kind of like an innocent bystander leaving a bar, and somebody started shooting, and one caught him in the back of the neck. Luckily for him, it didn't go through his spinal cord it didn't significantly destabilize his spine. It went through the back and caused the bullet track took it near the right C1 and C2 transverse processes. So he has fractures of those, and he has fracture of the lateral aspect of the C2-3 facet, but he didn't involve more than 50% of the facet. So we actually and the facet remained well approximated. So we got him flex X-rays, and he's stable on those. But He does have a dissection of the right vertebral artery, which happens to be his dominant vertebral artery. So he's being treated right now with aspirin. He's completely asymptomatic, and it's non-flow limiting. And then in terms of the last case, this is an unfortunate case, but it did prompt us to make some changes here at Elmhurst that have already been very helpful with these patients. So this is a 21-year-old who was in a hit and run. He presented with polytrauma with a severe TBI. He was GCS 6 in the field and then GCS 8 on arrival. But so he was localizing, no hypotension or hypoxia. And his CTA showed evidence of diffuse axonal injury with small great white junction contusions, IVH. He had no cerebral edema, had no hydrocephalus, and we got him a CTA because of the fact that he had DAI with a low GCS and skull-base fractures, and he actually had a left ICA dissection that was then causing a left M1 LVO as well as a left A1 LVO. So he was basically, he had a very severe ICA injury with complete occlusion of so thrombus formation, and then which then propagated and caused complete occlusion of the left MCA and the left ACA. So I bring this up because we have Viz.AI, which is it's both Sinai and we have it at Elmhurst, and this is basically an automated way to help detect LVOs. And so actually for this patient, we didn't have it. This is kind of in retro, we fed it into the system manually and him, but his case actually prompted us to, we have Viz.AI for stroke patients. And so all stroke patients that were coming in that were being flagged as a stroke code, their CTAs are going to Viz.AI. And basically what Viz.AI will do is it will use as an algorithm to help it determine whether or not there's an LVO or not. And then that's, if there is one detected, that sends out an alert to everybody that's on that system, including the stroke neurologists and the endovascular surgeons. But what we, at the time, and this was only a few months ago, at the time, we were not having all the CTAs done in the hospital fed through the system, including trauma ones. So a patient that was getting a CTA to screen for blunt cerebrovascular injury was not getting fed into the system. So in this case, the CTA we read manually, and we fed it back into the system on our own. But this case actually prompted us to change the protocol in our hospital. So now any CTA that is done in our hospital for any patient, you know, in the ED or any admitted patient, gets automatically fed into Viz.AI. And by doing that, it allows us to detect patients that may have a severe blunt or penetrating cerebrovascular injury that's causing an LVO and alert us potentially earlier than we otherwise would have been alerted. So he actually had his complete occlusion, and as you can imagine, you know, a patient with a complete occlusion normally without a TBI is, you know, time is of the essence. Well, it's even more constrained and more of the essence in a TBI patient, because in a TBI patient, they've already suffered an injury. So the brain already has initially decreased cerebral blood flow, whereas with an increased metabolic requirement, and now you then put a complete vessel occlusion on top of that, they are at extremely high risk of progressing to stroke very, very rapidly. And so because he was a low GCS, he had diffuse cerebral edema, he actually needed to get an EVD. So he actually got the EVD first on the way to the angio suite. It didn't delay the angio. The angio, basically, as they were setting up for the angio, he got the EVD essentially in the angio suite because we figured that he was going to potentially need to be on antithrombotic therapy, and then it was going to be a higher risk of putting the EVD in and causing bleeding. But you can see they did a very quick CT scan in the angio suite, and he was already starting to infarct a bunch of the frontal and temporal regions of the left hemisphere. But given his age and the complete occlusion in the dominant side, we knew that if we didn't treat him, he was going to have significant issues. So this is his pre-thrombectomy angiogram and then post-thrombectomy angiogram. So you can see he had complete occlusion of the ACA. He had some collateral circulation, some branches of the MCA still patent, but he had a Ticky 2B result after the thrombectomy, so he had some sluggish flow still, but he did recanalize. The issue is that because he had already, his stroke was already developing, he developed reperfusion injury with increased edema and hemorrhage, and he actually required going to the OR for decompressive craniectomy. He was then started on aspirin. He required several further decompressions and resection of infarcted brain tissue, as well as a shunt for TBI, post-TBI hydrocephalocystic cranioplasties. Unfortunately not doing well because that stroke ended up being quite large, but this just shows the importance of, screening very quickly for blunt cerebrovascular injury, and if possible, utilizing technology such as Viz.AI, like we have now, to detect LVOs in these patients as rapidly as possible, and that can shave off important moments to get patients to a thrombectomy if needed, and to get them to treatment. All right, so that's it. Thank you. Any questions? All right, so there's some questions on the chat. Question about traumatic vasospasm. Taught that traumatic SH does not cause spasm. Any thoughts or updates on that? So yeah, so basically what's been shown is that the amount of traumatic subarachnoid hemorrhage does not seem to correlate with traumatic vasospasm. So in other words, you can have traumatic vasospasm in the absence of traumatic subarachnoid hemorrhage, and those patients that have a lot of traumatic subarachnoid hemorrhage are not necessarily a higher risk than others to cause traumatic vasospasm. So the thought is that, unlike aneurysmal subarachnoid hemorrhage, where the vasospasm is probably related partly to the blood content and the breakdown products of the blood causing irritation, as well as potentially, the jet of blood initially from the aneurysm, that in traumatic vasospasm, the vasospasm is more caused by the kinetic energy than being absorbed by the vessels, and so it's a more kind of mechanical vasospasm. And so there may be some, I wouldn't be surprised if traumatic vasospasm or traumatic subarachnoid hemorrhage has some effect on vasospasm, but it doesn't seem to be so significant that they can find a specific, like a strong association between the two. So it seems that most of the most traumatic vasospasm, or the large component of traumatic vasospasm, is caused by the kinetic energy at the time of the injury being translated into the vessel walls. And so typically, traditionally at least, it's thought that traumatic vasospasm will appear earlier than it does with aneurysmal subarachnoid hemorrhage, so within the first couple days. Although I've seen it develop much later as well. I've had patients with traumatic subdural hematoma presenting with severe vasospasm later in the mission. First, many on the team did not believe it was phasing how to treat, evacuate this. Yeah. So again, yeah, I think most traumatic vasospasm tends to, and what the studies would tend to show, is that most of it occurs earlier, but I as well have seen some that appear to have gone into vasospasm delayed. That doesn't, again, it kind of flies in the face of, if it is really being caused by all this kinetic energy being transmitted to the vessel walls, why is it appearing so late? So it may have to do more with, potentially metabolic issues, a metabolic derangement of the brain and the blood vessels. I'm not entirely sure of the mechanism of why some patients have it much later. In terms of treating it, one thing I can say is that even though we will sometimes patients on nimodipine, there is no evidence that nimodipine works for traumatic vasospasm. So even in aneurysmal subarachnoid hemorrhage, nimodipine doesn't prevent the vasospasm. What it does do is improve outcomes in patients that have vasospasm, but actually doesn't really prevent radiographic vasospasm. So, and in traumatic vasospasm, the trials that have been done with nimodipine didn't seem to have an impact on outcome. So typically what we do we'll put them on nimodipine anyway, as long as their blood pressure can tolerate it. And then usually aim to ensure that they're, euvolemic or even mildly hypervolemic, certainly not hypovolemic, and then treat them with vasopressors and ensure that probably target a higher CPP, particularly if they're farther out and they don't have significant edema and they don't have and they're less likely to have ICP issues related to hyperemia. Then you can usually push their blood pressure higher, assuming they're symptomatic from it. I mean, in terms of evacuating the subdural hematoma, I guess it would depend upon, still how big it was and whether it was in the direct area of the subdural hematoma. If the subdural hematoma was not otherwise operable, I don't know that I would still necessarily do it, but I could certainly entertain the idea of doing that. And then endovascular treatment. Yeah, so I mean, if somebody has severe symptomatic vasospasm that is not responding to vasopressor and hypertensive therapy, then endovascular treatment for either angioplasty or intraarterial calcium channel blockers would be my next step as well. Any other questions? All right. Well, thanks folks for coming, and we'll put this up on the YouTube channel. So hopefully we'll get some more reviews on it there. All right. Thanks for coming.